Evening, everyone. We'll just let people jump in and join. All right. We might get started. So thank you all very much for joining us for our early treatment of COVID-19 positive patient session. Really excited to be offering you this session tonight in conjunction with our speakers. I think it's incredibly timely that we're doing a presentation on this. Next slide, please. So before we start, I would just like to acknowledge the traditional owners of the lands on which we're meeting today. North Western Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today, and recognise their continuing connection to land, waters and culture, and would like to pay our respects to elders past, present and emerging. For those of you that don't know me, I'm Bianca Bell. I'm the Director of Primary Healthcare Improvement here at the North Western Melbourne Primary Health Network. Thanks to Hamish, who's helping out in the back end. Just a little bit of housekeeping. At the moment, we've set it up as a webinar, so all attendees are muted. You certainly don't have to stay that way. If you do have a question, please raise your hand and come off mute and ask that. We'll also be answering questions through the Q&A function that you can see at the bottom of your screen there on the menu. This session is being recorded, so just wanted you to be aware of that. And it's really handy if we are sort of having questions from the audience to make sure that your name in the Zoom is correct if you're able to see that in the webinar view. So just a little bit about our agenda tonight. So we're going to have Dr. Nicole Allard to present on some sort of current trends and what we're seeing in COVID-19 at the moment. We're then going to have Alistair Miller and Joe Sasadeusz, who are going to talk us through some of the current treatments and particularly how they're accessed and who's appropriate for the treatments, contraindications, a whole range of information. So really excited about the session. Before we start, I do just want to welcome and officially welcome our speakers. So Dr. Nicole Allard, who many of you will know, is a postdoctoral researcher and medical epidemiologist at VHHITAL, also a GP, and is the public health lead for CoHealth and also a GP clinical lead with Alistair in the West Metro COVID positive pathway. We also are joined by Dr. Alistair Miller, who's a respiratory physician at Royal Melbourne Hospital and Peter MacCallum Cancer Centre. Alistair has been very involved in COVID, so working on the acute COVID-19 ward at RMH and as the clinical lead for the Royal Melbourne Hospital Virtual Hospital as part of the North Western Melbourne COVID positive care pathway. He's been a big contributor to health pathways on acute and long COVID, and also sits on the primary and chronic care panel of the National COVID-19 Clinical Evidence Task Force. So welcome to Alistair. We've also got Associate Professor Joe Sasadeusz joining us, who's an infectious diseases physician who subspecialises in medical virology. He's heavily involved in the education of GPs via the VHITAL program, and really lucky to have him here tonight. Also conducts several clinical trials, multiple clinical trials, and multiple research projects. So just a taster of the calibre of speakers that we've got tonight. I will hand over to Nicole Allard, who's going to talk us through some current trends at the moment. Oh, you're on mute, Nicole.
No, I just had one of those things where it went between screens. Hi, everyone.
Sorry.
Sorry for the bit of tech hopelessness at the beginning of the meeting. So I think I got the easiest job tonight because I don't have to say a whole lot of complicated new drug names and get them correct. And it's really exciting that we have the other speakers here to walk us through what is an increasingly complex area in general practice. So I was just going to, talk about where we're at. So, we all remember the bump, the wave. It's really now looking like a flat pancake on the scale of things. But we remember the wave in 2020, and then subsequently the more recent Delta wave which really kind of extends up towards Christmas of 2021. And then we were hit with the new kid on the block, the new variant that was way more infectious, and we saw a rapid increase in infections across our area. We all know this. Next slide. We're now definitely on the downhill of that, but I thought it was just interesting, and these are all publicly available data, to reflect that increasingly we're seeing people diagnosed by rapid antigen tests as opposed to PCR. In fact, if you go to a lot of testing places at the moment, they're not that busy. I think it's also interesting to reflect on who we're not seeing, you know, the hidden column of people who are either getting infected and not ratting positive, and they're not going on to have a PCR done when they're symptomatic, which I think is quite a common misconception in the community. And then we're also probably seeing some people who do rat positive, but for various reasons choose not to register them through the portal. So we've probably got, you know, a little bit of activity happening outside what public health can see. And that often actually ends up at the door of general practice. Next slide. And then if we look at age groups, so if we looked at this, so this is active cases in Victoria. If we looked at this graph in about nearly a month ago now, middle of January, it was a very different story. It was predominantly sort of the 20 through to 39 age group, and not many kids. But obviously with the return back to schools, we're seeing more of the school age kids. And the 20 to 29, I always call it the Great New Year's Eve transmission event, slightly tongue-in-cheek, but there was definitely a lot of transmission around young people during that period. And that certainly produced a lot of the spike we saw in early January. Next slide. So what's happening? Well, Omicron does seem to be a milder variant. In that if we look at hospitalised cases, and the Victorian mortality and morbidity data isn't as available as the New South Wales. So this is actually from one of the New South Wales weekly surveillance reports. So if we just look at hospitalisations in Delta compared with Omicron, it's quite a different story. So way more numbers, of course, and significant in terms of our hospital burden, but it is a milder variant. Now, I know there's been sort of some discussion about this, you know, across the board. Do we use this milder variant? But of course, we've also got a very highly vaccinated population. So again, the pre-Delta wave we'll ignore in New South Wales because they didn't really have as much COVID as we did. But during that Delta wave, we had 10% of cases hospitalised, and we were actually probably better at capturing the cases. You know, we're probably getting most of them, whereas there's way less with Omicron in terms of the number hospitalised. Okay, so and admissions to ICU very similar, and I think it's what we're seeing in our general practices, people with milder disease, and I think it's, you know, very timely to consider these new treatments in this setting. Next slide. Also from New South Wales, apologies for not being able to present data from Victoria, but the Public Health Intelligence Unit have stopped sending out their data packs regularly, so it's a bit unfortunate. But again, just showing that, you know, if you're unvaccinated, you are many times more likely to end up in hospital. So, you know, if we compare the elderly that we're particularly worried about, you know, 70 to 79, 3 or more effective doses, you know, much less likely to end up in ICU or die than if you are unvaccinated, less than 2 doses. So again, this is just reinforcing what we all know, that vaccination is also a very effective public health strategy. So we've had the nice sort of evolution of a milder variant, and we don't really know what's next, but we've also had vaccination, or the power of vaccination, influencing the outcomes in our hospitals. Next slide. That's all from me tonight. I'm not here to talk about the early treatments, but it's just to think about where we're going, and especially with regards to those treatments. I'm very happy to take any questions. That's no questions. I think it's over to you, Al.
Oh, thanks, Nicole. Hamish, I might share my screen if it's okay. Oh, I can just do that. Look at that. All right. As Bianca mentioned, I'm going to talk about budesonide and sotrovimab, look at the evidence for their use, current recommendations, and how we might deliver those. If you haven't looked at it, I can highly recommend looking at the disease modifying treatment algorithm put out by the National COVID Clinical Evidence Task Force. It's a really nice summary of all treatments that are currently recommended and at what time during the treatment course and for whom. But it's really the yellow part down at the bottom of this, which is looking at early treatments and particularly those who are not requiring oxygen, whether they have signs of a lower respiratory tract infection or not. And I'll start by talking about budesonide. And it's interesting that quite early in the pandemic, it was noted that those with airways disease were somewhat underrepresented in hospitalized cohorts. And so there are a couple of trials looking at inhaled corticosteroids, given that they're pretty low risk and very easy to administer. Inhaled corticosteroids are known to downregulate the expression of ACE2, and at least in vitro, that they've been shown to impede viral replication. The first study that was published was the Stoic Trial, a fairly small open label parallel group RCT, looking at budesonide or usual care. And they recruited any adult within 7 days of onset of symptoms. And they were treated with budesonide at quite a high dose at 800 micrograms twice a day for 14 days or usual care. And their primary outcome was urgent care visits with a secondary outcome of a reduction in symptoms. There were only 146 participants, half in each group. They were largely white, about half female, with a young median age at only 46. And they had a median of one comorbidity, and that was largely hypertension or hypercholesterolemia or indeed asthma. But the primary outcome showed that there was quite a marked reduction in presentation for urgent care, a 91% relative risk reduction for budesonide, which translates in a number needed to treat to avoid one hospitalisation of only 8 people. And if we look at the secondary outcomes, which is shown in this graph on the right, and this is looking at the rate of clinical recovery, and you can see that it is somewhat earlier in the budesonide group. The next trial was significantly bigger, again open label, but 10 times larger than Stoic, using the same dosage and treatment regimen for budesonide. But they aim to enrich for people who are at higher risk of progression of disease, and so anyone over 65 or over 50 with comorbidities was recruited into this trial. And they had co-primary endpoints of self-reported recovery or hospitalisation or death. Again, it was a similar cohort in terms of its demographics, largely white again, about half female, but a significantly older age, a mean age of 64. And again, a fairly low level of comorbidity. And they did show that there was an earlier initial reduction and sustained reduction in symptom of about 3 days. At peak, the symptoms were less severe, and there were improved wellbeing scores as well. And there was a non-significant reduction in hospitalisation or death. And so these are both relatively small, open label trials. And so the level of evidence that we can take from this is relatively low. And in fact, there wasn't enough evidence for the evidence task force to say that there was adequate evidence that there was changes in hospitalisation. But they did show, really from the principal trial, that there were fewer in the budesonide group who required supplemental oxygen at any time in the 29 days than in the standard care group. And on the basis of this, the budesonide has a conditional recommendation by the Clinical Evidence Task Force. And it's for consideration of use within 14 days of symptom onset in adults who have COVID-19 and don't require oxygen and have one or more risk factors for progression. And those risk factors are based on the principal trial. So over 65 or older or 50 or older with an additional risk factor. We know that inhaled corticosteroids, and particularly budesonide, is very safe in pregnancy and is also used in paediatric populations, and so also has a recommendation for use in these populations, although this is very clearly extrapolated data. So in terms of starting treatment, it's recommended that it should be started as early as possible in eligible individuals. But certainly within 14 days of onset. The only contraindication to its use would be any previous adverse effects from inhaled corticosteroids generally, or specifically budesonide. You do have to remember that it's a higher dose than is usually used at 800 micrograms, but either a 400 or a 200 microgram inhaler is fine. There is loads of drug in it for that 14-day course. The recommendation is for 14 days or really up to symptom resolution. There's no need for a spacer because it's a turbuhaler, and side effects are uncommon and known to all of you, dysphonia and oral candidiasis being the most common. And in my opinion, this is a drug that's very easy to give. It's very low risk of harm, and so really should be offered to anyone who is eligible according to those criteria. Of course,
Alistair, there's a question in the chat from Michelle just saying, what if a diabetic is on insulin? Should they be considered for budesonide?
Yeah, look, it's a really interesting question. I don't know why they excluded diabetics on insulin. The systemic absorption of inhaled corticosteroids is very low. And I think if a diabetic is on insulin, I don't think that should be a contraindication to the use of budesonide. And certainly that we know they're at risk of more severe disease. There is a question, of course, of whether it's a class effect or whether it's specific to budesonide. And there have been a number of studies, this being the largest one of ciclesonide or Alvesco. They'd planned, again, this is a true double-blind RCT with a placebo control. And they'd initially planned to look at hospitalisation, but the hospitalisation rates were so low, they changed their primary endpoint to alleviation of all symptoms. We know, unfortunately, that many people have at least some symptoms ongoing for weeks or even months. And so I think this was always going to be a fairly bold plan. And ultimately, they didn't show a difference in the time to alleviation of symptoms. They did show a lower emergency presentation rate of 1 versus just over 5%, but it wasn't powered to really show that. So the next drug, of course, is sotrovimab. And sotrovimab,
just before you move on to sotrovimab, just another question. Just a question about if an asthmatic is already on another steroid inhaler, should we change them all?
No, look, I don't think we should. I think it's a really good question. I don't think we should, but I think we should be ensuring that they're on a dose equivalent of 800 micrograms of budesonide, and there are good references to show what a dose equivalent is. But I wouldn't be changing medications. I'd simply be ensuring they're on an adequate dose. So sotrovimab was an antibody found actually by screening serum of a patient who recovered from SARS-CoV-1. So of course, early in the pandemic, Vir Biotech had a look to see if it was active against SARS-CoV-2, and fortunate for us, it was. I show this partly because it's quite a cute picture, but it also just shows how sotrovimab binds, and it binds to the spike protein receptor binding domain. So it's the purple bit, and it binds away from the actual receptor binding motif that binds to ACE2, and it leads to neutralization of the virus to stop it entering cells. But it also has the potential to recruit immune cells and destroy already infected cells. The binding area is highly conserved, and the Vir Biotech have recently released a preprint showing that it maintains activity in all variants to this point. There is ongoing testing occurring with the B2 variant of Omicron, but their current position and that of GSK is that they believe that recommended dosing will be adequate for neutralization. So the study that our use is based on is the COMET ICE study, where they randomized about 1,000 people to either sotrovimab or placebo, and it was in a group not requiring oxygen who had risk factors for progression of disease or severe disease. And that was anyone over 55 or those who had comorbidities, which included obesity, diabetes, airways disease, chronic kidney disease, and cardiac disease. And it was, in fact, a fairly young group. This is from the full study population that had day 29 data. The median age was only just over 50, and only 1 in 5 of them were 65 or older. Again, it was a largely white or Latinx population, and they were obese. And this study was almost exclusively in North America. So the vast majority of people who were in the trial were eligible on the basis of either obesity or age. You can see that there's really very small numbers of people who had chronic kidney disease or cardiac disease, and indeed not terribly many who had airways disease. More than half had only one condition, and about more than 3/4 had only 1 or 2. But the headline from this trial is that treatment with sotrovimab reduced the need for hospitalization by 79% as compared to placebo. There were only 2 deaths in the placebo group and no deaths in the sotrovimab group. And on the basis of this, obviously, sotrovimab has been given a conditional approval. In addition to these numbers, though, I think it's interesting to look at those people who did end up in hospital, and obviously it was only half a dozen in the sotrovimab group. But this just shows that the different oxygen requirements, or indeed the severity of disease as a surrogate of severity of disease, that with the green being low flow oxygen, the sort of tan bar being a non-rebreather or high flow, or indeed non-invasive ventilation, the yellow being invasive ventilation or ECMO, and the magenta spots at the top are the deaths. And you can see that while all of those conditions occurred in those who'd had the placebo, it was really only low flow oxygen for those who had sotrovimab. With regard to adverse events, there really weren't any significant differences. There was numerically more diarrhea, but it was generally mild. And there was no difference in infusion reactions between the treatment and placebo arms. Of note, there was a single episode of anaphylaxis that's been reported in a hospitalised patient in the post-authorisation experience, but not within this trial. So the summary really is that in the intention to treat analysis of more than 1,000 people, sotrovimab significantly protected from hospitalisation and indeed death. And it was generally safe with usually mild side effects. And so in contrast to the budesonide story, this is taken from, again, from the National COVID Evidence Task Force. And there was a significant reduction, 46 fewer per 1,000 in hospitalisation or death. And this is really all in the hospitalisation arm, while there was numerically less in deaths in the sotrovimab arm, but there weren't enough events to reach significance. And serious adverse events were really to do with COVID pneumonia, again, as expected. And so sotrovimab has a conditional recommendation, and the recommendation is that it should be given within 5 days of symptom onset in unvaccinated adults with COVID-19 who don't require oxygen and have one or more risk factors for progression. And it's really entirely based on the COMET ICE trial. And so those risk factors, again, age 55 or older, diabetes requiring medication, and importantly, as I'll note in a moment, not gestational diabetes, congestive heart failure, COPD or moderately severe asthma, which is defined as being on a long-term inhaled corticosteroid or requiring oral steroid in the last 12 months, chronic kidney disease with an eGFR less than 60, and obesity with a BMI of greater than 30. But one of the problems we have at the moment is the supply for sotrovimab is an unknown quantity. And so there's been some work done looking at a prioritization framework so that we can ensure access for those who are most likely to benefit.
Alistair, there's another question. Just with sotrovimab, how many times can sotrovimab be given? So if someone had sotrovimab and had Delta and then subsequently catches the next variant, can it be given again within a certain time period?
Look, it's a really good question, and Joe might want to pipe in. Look, my understanding is that it can be given again. I think the current recommendation is not to give. Not to be vaccinated within 3 months after sotrovimab, and so I think there is a feeling that the effect of it does persist for some time, but I don't think there's if it is the best drug to be given, then I don't think there's a reason for it not to be given again in subsequent waves.
And there's also a question from Christina, but I think you're about to cover it in looking at the immunosuppressed group. So I'll let you proceed.
Yeah, thank you. So there are some other recommendations by the task force for the use of sotrovimab, and they didn't reach the same, well, 2 of them at least didn't reach the same level of recommendation as the initial recommendation, and those are for the immunosuppressed populations, or those who are under vaccinated. And the reason that they can't make a stronger recommendation is that these, at least to this point, these populations haven't been studied, and so it is extrapolated on the basis of the previous study, and so that the recommendation is in place, but it's a consensus rather than a conditional recommendation. There is a conditional recommendation for the use in pregnancy, and again, this is for pregnant women in the 2nd or 3rd trimester who have one of those previous risk factors. It includes diabetes that is not gestational in nature. And there's also a consensus recommendation for the use in children, and it's any children and adolescent who are 12 years and over, weighing at least 40 kilos. And the risk factors are somewhat different, and the primary one is pediatric complex chronic conditions, but also severe asthma or obesity. So in terms of local supply, there's been understandably a very rapid rise in use, up to over 120 doses a day from late January onwards, but it is starting to peter out. And we crossed through the 5,000 doses given earlier this month. So as I mentioned, the infusion must be given before the end of day 5, where the day of symptom onset is day 0. There are a number of jurisdictions around the world that are using extended time points, but really from the trial, that everyone in that trial, bar one person, were treated prior to the end of day 5. So we don't have any evidence to suggest that will change. Referral to infusion centres is largely done through the COVID positive pathway. Some centres will accept GP referrals and referrals direct from specialist physicians. But eligibility according to those criteria won't guarantee infusion, and priority has to be given to those at higher risk. And I'll show you a prioritisation framework that was released yesterday. The infusion is over 30 minutes. There's an observation for 60 minutes afterwards. And as I said, the recommendation is to wait 3 months before subsequent vaccination. So this is the matrix, and this is based on really the knowledge that we have both from local data and international data that age is really one of the strongest determinants of hospitalisation. And so those who are older, particularly older and unvaccinated, remain a very high priority and should be prioritised for supply. We know that immunosuppressed individuals are unlikely to produce an adequate response to vaccination, and so they also are prioritised. And then there are a number of other groups that we know are at risk of severe disease and so have been prioritised, and those are women who are pregnant, particularly unvaccinated, and Aboriginal and Torres Strait Islander populations. And at this point, the statewide recommendation, and it is that it's only people in tier 1, 2, and 3 who will be offered sotrovimab. When there is unlimited and indeed known supply, we will consider other groups, but at the moment, the feeling is that we should be prioritising those who are most at risk and most likely to benefit. Hopefully there is more data coming. Hopefully in the next few days, the Comet Tail, I think, trial will have some results. And this is the Comet Tail is a non-inferiority efficacy trial looking at IV versus IM administration of sotrovimab, and indeed extending that out to 10 days, 7 days, rather than 5. There are also studies looking at paediatric populations, the immunocompromised, and indeed using it in other settings. Finally, there are a great number of infusion services around both Metro Melbourne and indeed regional areas. And this is available through, I understand, through the health pathways, but also through the Department of Health site. Thank you.
Alistair, there are a few questions. Christina just asked about previous cancer history. I think this is sort of relevant, especially for how recent cancer history or recent cancer treatment should be taken in light of this. Like, is it in the last year? You know, what are the kind of cutoffs for considering cancer history of non-hematological malignancy?
Yeah, so solid organ tumours, treatment within the last 12 months is considered as a risk factor. But in fact, certainly speaking to ID colleagues, the level of immunosuppression in solid organ tumour treatment is much less than that in that associated with hematological malignancy. But outside that 12-month period, in the absence of any other immunological consequence of treatment, of prior treatment, then people would not be considered at higher risk.
And just a further question, she was just asking if what you mean by immunosuppressed due to chemotherapy, immunotherapy, or for autoimmune disease. There is a criteria on health pathways, I think, of what is considered immunosuppressed for sotrovimab, I think. So we can cover that when we look at pathways. There was also a question about is it as effective against Omicron as most of these studies were done for Delta or previous variants?
Yeah, look, it's a really good question. And I did make reference to a preprint from Vir Biotech, who developed this with GSK, and in vitro, at least, they have shown that there is activity against the B1 variant. There's ongoing testing against the B2 variant, and that isn't conclusive as yet. But certainly all the variants to this point, in vitro at least, it has been shown to be active. And we don't have anything clinical at this point to suggest otherwise.
So Alistair, just sorry to interrupt, there was an Aaron Diamond publication earlier last week which actually suggested that the 1B variant was actually not inhibited by sotrovimab, which was then contradicted by GSK. So I think the jury's out.
Yeah.
Luckily, we don't have 1B in significant numbers in Victoria, but if we do, we really need to know the answer to that.
Absolutely.
Yeah.
And Karen's just asking the logistics. Tried to refer a few who refused based on, is there parking? I can't drive to Sunshine due to roadworks. Can an ambulance take me? And I think it's particularly relevant for people who don't have cars. What are the logistics of getting someone to their infusion?
Yeah, so look, it is a really good question. And we have moved to self-transport as much as possible, simply because our other option is non-urgent ambulance. And certainly at the peak of this wave, non-urgent ambulance was not an option in terms of getting people to these services in a timely fashion. But all services should be able to arrange transport if the patient is not able to transport themselves. And we all accept that that's a very reasonable thing. If you and everyone else in your household is feeling rubbish, the last thing you want to be doing is driving. And so transport can certainly be arranged.
Lester's just asking something about budesonide. Does vaccination status affect the decision whether or not to give budesonide, or are we just giving it if they've got risk factors?
Yeah, look, we don't know the answer to that. There is no one, not significant numbers in the trials. My feeling is it's incredibly low risk. I think if people have symptoms, then it's reasonable to give it. We don't know what the effect of it is. I think if people are not symptomatic, then there's no reason to give it. But I think it would be reasonable if they have symptoms.
Okay. There's also a tricky question, but not related directly to sotrovimab or budesonide, and Joe, you can weigh in. So Rasika was just asking, is it best to actively catch the latest variant after triple vaccination for healthy, non-obese individuals? Since it will be a mild symptoms, you'll get a better exposure to the viral components, not just the spike protein.
Do you want to go with that one now? I'll give you first go at it.
So my Tuesday morning for the last 18 months or so has been a long COVID clinic. And I think ongoing symptoms following a mild infection, I don't think are affected by the severity of the original symptoms. We've certainly seen people with very long-standing fatigue and exertional breathlessness after having very mild acute infections. So I don't think we can recommend getting it because it might make things better later.
Yeah, I agree, Alistair. It's not something that's recommended. I mean, I guess this is the equivalent of having a chickenpox party, but you can't bank on the fact you're going to get a mild case, even though most cases are. And B, as Alistair says, there's the issue of long COVID, even if you do have a mild dose. So I think it's in the don't try this at home basket.
There's Richard's just asking, there's talk about doxycycline. Is there any evidence about this being affected or recommended?
Not at this point. It's certainly not got to the level of being considered for recommendation.
And a question about the incubation infectivity times for Omicron.
Well, I'll leave that one to Joe.
I think they're pretty much the same as they are for the other variants, Nicole. I don't think they're different.
I think the Omicron's a bit shorter incubation. I mean, I think it's interesting. CDC moved from 7 to 5 days, but we know people are often symptomatic and infective beyond then. So I think it's also about your kind of the trajectory of how many people you've got in your community as well, and how much transmission you're trying to stop. There's a question about the risk of long COVID in percentage. So what would we say previously, prior to December?
Look, it depends. It depends how you define it. You know, somewhere around sort of 20 to 30% at 3 months will have some ongoing symptoms. It falls off, but there is there's a stubborn, maybe 10% who have ongoing symptoms to 12 months. I think it's a very difficult thing to define, and it depends very much who you ask and how you ask the question as to the precise percentage.
There was a study saying that the long COVID was reduced in people who were vaccinated up to 40%, but I guess that still has a substantial number of people being affected.
Yeah.
And there's a question, will any steroid do, or does it have to be budesonide? Some HIV positive patients who are on protease inhibitor boosters can only be given beclomethasone due to drug-drug interactions.
Yeah, look, I think that's fine. We obviously don't have the evidence, but we need to do what's appropriate for the patient, and provided we can give a dose equivalent of beclomethasone, I don't know what that is off the top of my head, then my feeling is that that's the most appropriate thing to do.
So a question comes from data where patients actually became Cushingoid when their asthma was treated. So I guess from my point of view, would a short course really be that significant in terms of steroid effects? Al?
Look, I don't think it's a very short term treatment. We wouldn't expect people to become Cushingoid with, in a non-HIV sense, with 2 weeks of oral steroids. So I think it would be unlikely for that to occur with just 2 weeks of inhaled steroids.
And there's also a question, it seems most people after 7 days of ISO don't continue to wear masks after leaving the house. Why is this message not getting out there? Couldn't it be fueling ongoing infections? I'm happy to take that. The answer is yes, it can if people are still symptomatic. And there is actually advice on the website to be cautious around not to go into high-risk environments for a further week after you leave isolation. But I think you're right, Michelle, it's pretty lost. People aren't necessarily hearing that.
Thanks, Nicole. And thanks for all of those questions. We'll hand over to Joe now for his presentation. Thanks, Joe.
Thanks, Bianca, and thanks, Nicole. So my part of it is to particularly cover the new kids on the block, which are the 2 new oral agents that literally are about to be released as we speak. Next slide, please. So this is the list of agents that we have, and they're divided into agents for early disease, currently covered, and other indications for later disease. And you can see in early disease, there's budesonide, monoclonal antibody, which now really only means sotrovimab because Ronapreve doesn't work against Omicron. And then we have the direct antivirals, which are what I'm going to talk about. The 2 drugs that are the new kids on the block are molnupiravir, and the other drug is Pexlovid. And I have no doubt that most of you would have heard at least some information about these drugs. The 3rd drug, which I will not cover, is an IV formulation of remdesivir, which has previously been used in later disease, but there's evidence to suggest IV administration can also reduce progression to severe disease. So I mainly covered the 2 drugs in orange, molnupiravir and Pexlovid. Next slide, please. This is to remind you about the natural history of the disease itself. And it's important to remember that the first week of illness roughly is what we call the viral response phase. Patients have mild constitutional symptoms. They have a dry cough. They often have a lymphopenia. They're not hypoxic, and they are essentially miserable. And this is the time frame during which we use the antiviral agents and the monoclonal antibodies. The disease then moves into a second phase, which is mainly mediated immunologically, and you'll see most of the drugs in the grey that are used in this phase are actually immune modulating drugs. And that's when people actually get pneumonia, they get hypoxic, they end up in hospital, and eventually there's a third severe phase that manifests as ARDS and septic shock. Next slide, please. So let's move to the first of these. Like most drug companies, the names are almost unpronounceable. The first drug is molnupiravir, otherwise known as Lagevrio, which sounds like Lothario, but anyway, there it is. And that's the first oral drug to be registered by the FDA. Next slide, please. Like all virologists, I have to put in a viral life cycle just to highlight where these drugs work. So molnupiravir is a polymerase inhibitor. So it inhibits the RNA polymerase and blocks replication of the viral RNA template. Next slide, please. So the summary of the actual drug itself, it's an oral administered ribonucleoside prodrug. So it's a nucleoside analog like a lot of the drugs that we use already, such as acyclovir. It's a repurposed drug that's been around for a while and has broad activity against a range of RNA respiratory viruses that clearly include SARS-CoV-2. So what I mean by a prodrug is you have a parent drug that is taken orally that has high absorption, and it's then broken down once it's in the circulation to the active agent, which is then the drug that actually does the job. So it's a way of getting high levels of a drug in that normally would have low absorption. And the oral drug that does, oops, not yet, can we go back, please? The drug that does the heavy lifting is a drug that's named there, and I will merely call it NHC. And then it has to be triphosphorylated before it's incorporated into a growing RNA chain. The important other issue is that the main mechanism of action of molnupiravir is that it inhibits viral replication after its incorporation by accumulation of mutation. So unlike other nucleoside analogues, which are chain terminators and basically just block replication, it induces errors and mutations. And the mechanism by which that causes a non-viable virus is a mechanism called viral error catastrophe. Next slide, please. So the major clinical trial that molnupiravir is based on is what we call the Move Out trial. There were two major trials. There was a Move In study, which is in hospitalized patients, which was terminated due to lack of efficacy. And we're going to concentrate on the Move Out study. And it's a phase 2 randomized double-blind controlled study to evaluate molnupiravir in non-hospitalized patients. The patients that we're talking about that were included in the study were 18 years and older, PCR-confirmed COVID infection, not requiring hospitalization, and who are symptomatic. The primary endpoint were two major endpoints. One is the proportion of patients hospitalized or dying through day 29, as well as adverse events. So when you look at these studies, conventionally, the standard is now in early treatment to look at hospitalization and death at a certain time point as your primary endpoint. Next slide, please. So this is the design of the two parts of the study. The phase 2 component evaluated 3 doses of molnupiravir versus placebo. It was done in 300 patients, and on the basis of that, 800 milligrams was determined to be the appropriate dose to take forward into the phase 3 part of the study. And you can see in the bottom panel, the phase 3 part of the study, which was conducted in or meant to be conducted in 1,550 patients, so a much larger study, was a 1-to-1 randomisation of molnupiravir 800 milligrams twice a day versus placebo over a period of 5 days. Next slide, please. Eligibility criteria, we've touched upon it to some degree. Laboratory confirmed co-infection and onset of symptoms less than 5 days prior to randomisation. So pretty much the same as what you saw with sotrovimab when Alistair presented it. And obviously participant, like the sotrovimab study, had to be at increased risk of severe disease from COVID. And this was defined as age greater than 60, active cancer, chronic kidney disease, COPD, obesity defined as a BMI greater than 30, serious heart conditions defined as coronary artery disease, heart failure and cardiomyopathy, and diabetes. So not quite the same, but quite similar to the approach that you saw in sotrovimab. This was in non-vaccinated patients. Vaccines were prohibited any time prior to randomisation through day 29. And remember, this study was done before wide rollout of vaccination. Pregnant individuals were excluded and contraception was required, and we'll talk more about that in a moment. Next slide, please. So there was an interim analysis. With these studies, what they often do is they get a data safety monitoring board, which determines interim efficacy halfway through the study. So this is exactly what they did. And what they found was that there is a significant effect of molnupiravir on hospitalisation and death. So 7.3% met that endpoint in molnupiravir and 14% in placebo, suggesting an effectiveness rate of roughly 50%. And importantly, there were no deaths in the molnupiravir arm and 8 deaths in the placebo arms. So far, so good. The other thing to state is that 40% of the patients had sequencing data that told you which variant they had, and it worked equally well against all the variant, although we do not have data clearly on Omicron. This was done before Omicron emerged. And on the basis of this, the DSME just suggested that the study be stopped and application for emergency use authorization be submitted, and in fact that was granted. Next slide. What then happened is that they then analysed the full data set. So whilst all this was going on, patients continued to be accrued, and therefore this is the actual final data set. And what you can see is that hospitalisation rates in the molnupiravir arm were roughly the same at 6.8%. However, the placebo arm hospitalisation rate dropped quite significantly down to 97%. And the bottom line is that at the final analysis, once all the patients were recruited and analysed, the efficacy rate had dropped to 30%. So it still worked, it just didn't work as well as was suggested in the interim analysis, and certainly not as high as what we saw with sotrovimab. Next slide, please. The other thing is how safe it is. Well, the drug is very clean in terms of adverse events. You can see when you look at adverse events and adverse events that cause discontinuation of drug, they were similar or less in molnupiravir. In fact, the SAEs that you can see are higher are probably due to the fact that these patients went on and developed complications of COVID. And if you look at the most common AEs in greater than 1% of the population, they were really diarrhea and nausea, and they were barely higher than the placebo arm. So the drug is actually very clean. Next slide, please. The formulation is that it comes in 4 200 milligram capsules, which are actually quite large. So some individuals have been found to have difficulty swallowing them. And so it's twice a day formulation, taken 12-hourly for 5 days without regard to food. Can be taken with or without food. And obviously you need to take it as soon as possible after a diagnosis, and certainly within 5 days of symptom onset. Next slide, please. Other things you need to know about this drug is that it's not authorised in patients under the age of 18. In fact, there is some data that it may affect bone and cartilage growth in young individuals. It may be used regardless of COVID-19 vaccination status, although the data is in unvaccinated patients. Breastfeeding is not recommended during treatment and for 4 days after the final dose. Unlike the next drug, there are no drug interactions that have been identified based on limited data, but it looks like it's pretty clean in the way of drug interactions. And no dosage adjustment is recommended in patients with any degree of renal or hepatic impairment. Next slide, please. The issue of pregnancy is quite an important one. So firstly, based on animal data, it can cause fetal harm when administered to pregnant individuals. Now, there is a caveat that's put out by the FDA suggesting that occasionally, if you really need to use it, you think the benefit outweighs the risk, then you could consider it with appropriate patient information and consent. However, I'm not sure that with a drug that works with that mode of action, particularly if it induces mutations, that I would be comfortable using in any pregnant women. Next slide, please. So the other issues is that, remember, the mechanism of action is error catastrophe. So it has, as we've alluded to, potential for teratogenicity, which has been identified in animal studies. And remember, this is the mechanism of action to another drug, ribavirin, that we certainly have concerns about with teratogenicity. And the other concerns by the FDA was because of its mutational induction potential, that it may potentiate antiviral resistance, although that's a theoretical concern at this point in time. So clearly you should not use the drug in pregnancy. And in my mind, I think you should probably even do a pregnancy test at baseline if you're going to use it in women of childbearing potential. Next slide, please. Okay, let's move to the other, even newer drug, which we know as Pexlovid. It is a combination of two drugs called nirmatrelvir and ritonavir. Again, another mouthful that the marketing people have really given to us. So this is a slightly different drug. It's a protease inhibitor, and it was a protease inhibitor that, rather than being repurposed, was actually specifically designed to work against coronaviruses. And in fact, it virtually works against all known human coronaviruses. Next slide, please. Again, if we look at the viral life cycle, you can see that this works against the viral protease. Now, what a protease does is that when viruses replicate, they make polyproteins when they transcribe the RNA. So they make large bits of protein, which then have to be cut up into appropriate sizes. And if that doesn't happen, then obviously you have a non-viable virus. And that's where proteases work. And we've dealt with proteases in the past. Some of you would have managed HIV patients and Hep C patients where other proteases are in use. Next slide, please. The other issue is that the ritonavir is there to actually improve the pharmacokinetics of the parent drug, which is niltemravir. And you can see here that on its own, the parent drug in blue decays in terms of its PK pretty quickly, but when you give it in the context of ritonavir, you actually improve its PK above the IC50 and maintain it for a much longer period of time. So really the ritonavir is purely there to improve the pharmacokinetics of the parent drug. The problem is that the ritonavir, by blocking cytochrome P450, also has the potential for drug-drug interactions. And we'll talk about that again in a little while. Next slide, please. The formulation here is that it is formulated as two 150 milligram tablets. So each dose is 300 milligrams, together with one 100 milligram tablet of ritonavir. Now, those three tablets have to be taken twice a day for 5 days, again, without regard to food, and again, as soon as possible after COVID diagnosis, but certainly within 5 days of symptom onset. It comes in a packet with 5 blister packs, one for each day of administration. Next slide, please. So what about the clinical data that supports it? There are a number of clinical trials that were done with this drug. The one we're going to focus on is the EPIC-HR study, which is the top panel, and that is in high-risk patients. And this was a global phase 2-3 clinical trials, quite similar in design to what we saw with molnupiravir. The planned patient recruitment was to be 3,000, and again, for the same reasons as we saw with molnupiravir, because of early termination, the final patient numbers were 2,246. Next slide, please. The inclusion criteria, very similar to what we saw before. Patients needed to be over the age of 18. They needed to have confirmed SARS-CoV infection by PCR within 5 days of randomisation. And the signs and symptoms also had to be within 5 days of randomisation. They need to have had at least one COVID sign or symptom present at the time of entry, and they needed to have one high-risk condition for severe COVID, as you saw in previous studies. Next slide, please, sorry. Top line results, as we said, the final data set was 2,246. There was, again, like we saw on the last study, an independent data monitoring committee that analysed the data as an interim analysis after 45% of patients had been recruited. The study itself was a straight one-to-one randomisation to receive Pexlovid or placebo for 5 days. And at the time to stop recruiting, 75% of those patients had been recruited, which was high. They ended up at 2,246 patients. Next slide, please. So here's the bottom line. The primary endpoint was, in fact, the reduction in death or hospitalisation from any cause compared to placebo, which is identical to what we saw in the other two studies. And that was within 3 days. That was a primary endpoint. And you can see that the protection was 89%. So of the same order as what we saw with sotrovimab. And this is not only with the interim analysis, it held for the full analysis, unlike what we saw in molnupiravir. And if you look at it within 5 days, there was an identical result at 88%. So the drug was highly effective at protection from hospitalisation and death in this patient population. Next slide, please. In terms of safety, again, very clean in terms of treatment emergent adverse events, serious adverse events or adverse events leading to discontinuation. If anything, lower than in placebo, and certainly overall AEs similar to placebo. So it looked clean. Next slide, please. In terms of AEs that occurred in greater than 1% of patients, we can see that probably dysgeusia or an abnormal taste was the most common, 6% versus 1%, maybe a mild signal for diarrhea, but hypertension and myalgia occurred at similar rates to placebo. So relatively clean, with perhaps dysgeusia as its major signal. Next slide, please. The other issue for us is that Pexlovid is a CYP3A inhibitor and is also metabolized by CYP3A4. So as a result of that, two things may happen. The drug may increase the plasma concentrations of drugs that are metabolized by CYP3A4, or medications that inhibit CYP3A4 may increase or decrease Paxlovid concentrations depending on what they do. So there are two consequences of this. You can get clinically significant adverse reactions, including potentially fatal events from greater exposure of concomitant medications, or you can get loss of therapeutic effect of Paxlovid and possible emergence of viral resistance from decreased Paxlovid serum levels. So clearly there are major issues if you don't get these drug interactions right. Next slide, please. So clearly what we need is a way to manage these interactions. And again, those of you on the call or the webinar who have dealt with HIV or Hep C are used to doing this. And there is a tool called the Liverpool Drug Interaction website. It is a tool where you basically plug in the drug that you want to use, patient's concomitant medication, and it tells you potential interactions for that combination. And there is now a dedicated Liverpool website specific for COVID-19 that you can download onto your desktop, tablet, or your phone. And it basically tells you interactions in 3 different categories. There are red, where you can't use the drug. There are orange, where you may be able to stop the drug temporarily, as in a statin, for example, or you can adjust the dose of the drug, but you need to pay attention to potential interactions. And the third group is green, where there are no significant interactions. And this tool for us will be key going forward to assess our interactions, with obviously a backup of an experienced pharmacist if we get anything that's a bit more complicated than the Liverpool website can inform us on. Next slide, please. The other issue is renal impairment. Unlike molnupiravir, normal dose can be given in an EGFR greater than 30, but if the EGFR is moderately impaired at 30 to 60, you need a dose reduce, which means you give a 150 milligram dose, so 1 tablet rather than 2 tablets, together with the standard dose of ritonavir, and again, it's twice a day for 5 days. If the EGFR is less than 30, it's not recommended, as the appropriate doses haven't been determined. So clearly, calculation of the EGFR is important in administration of the drug as well. Next slide, please. Other specific population, no dosage is requirement for mild or moderate hepatic impairment. It's not recommended for severe hepatic impairment, which is really patients with liver failure with a Child-Pugh class C severity. Pregnancy and lactation, again, there is no available data on Pexlovid in pregnancy or with breastfeeding. There is some data from animal studies that at 10 times the dose that we give to humans, that there's a reduced fetal body weight. The significance of this is unclear, but at the moment it's not recommended to use in pregnancy or lactation, and there's no available clinical data in children. Next slide, please. There are a few other caveats. You have to remember that both these studies did not include any immunocompromised patients, which is a patient population that we are intending to use this in. Neither study included vaccinated patients, and I might add that it didn't include any patients with the Omicron variant. No pregnant or breastfeeding women are included in the studies, nor were children. So a lot of our eligibilities for immunocompromised, vaccination status, and Omicron are extrapolated from the studies as they stand, and the prescription of the drug is limited to individuals 18 years or older. Next slide, please. The eligibility is here, and I'm sorry it's a complicated slide, but this is essentially the summary of the inclusion criteria or eligibility criteria, as Al has told you. Now, the problem is, Al has probably not been aware that there's been a lot of chatter whether these are appropriate, and there's been a lot of colleagues who are concerned that there are individuals in this eligibility that probably are relatively low risk and others that are high risk that haven't been included. So this is almost certain to change over the next couple of days. So watch this space. Next slide, please. What about access? This is still a work in progress. The stockpile is being managed by the National Medical Stockpile, as was the case for remdesivir and sotrovimab and Ronapreve. Unfortunately, the government has decided that the initial distribution would be via tertiary centres, with the Alfred as the central repository for Victoria. I'm a big believer that this drug should be in primary care, but in the short term, unfortunately, will not be. It will soon be PBS listed, probably in the next week or two, and eventually it will be rolled out to primary care with a streamlined authority. Now, we hope that this will happen in the next 3 months or so, but we're stuck with this clunky interim model of tertiary centres in the meantime. Next slide, please. So in conclusion, I'm sure there'll be a lot of questions related to this. Oral antivirals are now here for early COVID, and they have efficacy, but various degrees of efficacy. They are used like sotrovimab in individuals within 5 days of symptom onset who are not hypoxic and are at increased risk of disease progression. Pexlovid has particularly high efficacy, but has a lot of drug interactions which need to be evaluated. Molnupiravir, on the other hand, has no drug interactions, but it has modest efficacy. So I think we really need to think about what drugs we use based on, firstly, what is the best available drug for that patient, whether drug interactions can be overcome, and thirdly, the availability of these agents, which Alistair has already told you is limited and may get more sparse as time goes on. Next slide, please. So I'll thank you and stop there, and I'm sure there's a lot of questions that we'll be fielding around this. Thank you.
Thanks, Joe. We've got a couple of questions relevant to those two drugs. Brad just asks, in the Pexlovid study, many patient groups were excluded due to potential drug interactions. Consequently, do you think the less sick population was recruited compared to the molnupiravir study, which did not exclude any patients for drug-drug interactions?
Look, I think if you look at the actual mortality rates in the two studies, they were probably similar. So I don't think there was much of a difference. The one thing that was odd was that the mortality in the placebo arm dropped from a very high 14% down to about 9% in between the interim and the final analysis. But I think a lot of us believe that those studies included a lot of patients who probably did not need treatment anyway. They were very loose in their definitions of who was high risk. So I think that actually applied to both studies, not just specifically the Pexlovid study.
And a question about molnupiravir potential for teratogenicity. Is there any implications for men who are planning on fathering children in the days, weeks after treatment?
The answer is yes. And if I recommend, men should not father a child for, I think it's 4 months after they've taken molnupiravir. I'll just double check on that, but it's a considerable period of time. So yeah, like ribavirin, it applies not only to women, but men as well.
And this is a question for both you and Al. Can you comment on supplies of each agent, as that will also influence usage? And how would you choose, basically? I think it's also worth saying that while there is the sort of central coming via state through the Alfred, there has been doses sent to Aboriginal medical services and aged care settings. Yeah. So this might actually be where GPs encounter the first kind of tranche of the drug.
Sure.
Any comments about how to choose?
Al, well, I guess the first question is around availability. So let's do that first, and then we can do the choice, Nicole, if that's okay. Al, sure. Did you want to comment on availability, and then I can chime in with my 20 cents worth?
Yeah, look, it's a really difficult question to answer. We know that there were 8,000 doses coming in of a combined Paxlovid and molnupiravir, the majority of that being Paxlovid, but there are another 20,000 doses coming of molnupiravir. The difficulty is we don't know how much of that is going to come to Victoria and how it's going to be distributed. And as Nicole mentioned, we know that there are a number of residential facilities that have received molnupiravir already, and the plan is for all facilities to receive a small supply, but a supply nonetheless of molnupiravir over the next sort of week and a half to 2 weeks. But the remainder of it will go through hospital pharmacies, with the exception, I don't know if Nicole mentioned this, but Aboriginal medical centres will also be getting their own supply of molnupiravir outside of this program.
So the other thing to add is the supply will be a moving feast as we goes on. So what we're told by the companies is that sotrovimab, they originally bought, I think, 30,000 doses. and they've subsequently ordered another 40-odd thousand. So overall, it'll be 70 to 80,000. So that's what we will have eventually, and we're told by GSK that that supply will be secured for Australia, despite the fact that there's chatter about a global lack of supply. The total number of doses of Pexlovid, the first tranche is 30,000, and I'm presuming the 8,000 Alistair is talking about is the portion that's been given to Victoria. Is that right, Al? But the total number of courses that have been purchased by the government is 500,000, and I think Molnupiravir is 300,000 courses. But obviously they won't all come at once, so this will be a moving feast. And in terms of prioritisation, we may have to further restrict prioritisation if we come across shortages of various different drugs. So that's going to be a movable feast as well.
How to choose?
Choice, I think once Paxlovid comes online, and Al will have his own opinion on this, obviously. I think because it's an oral drug, number one, and I think, and the FDA has sort of said this already, number one choice would be Paxlovid. It has a very high efficacy. It can be oral administered and can eventually be distributed through primary care. It makes a lot of sense. My number two would be Sotrovimab in situations, particularly with drug-drug interactions where basically you can't give Paxlovid. Let's say you have a patient on warfarin or a NOAC where it's an absolute no and you can't give it. I would reserve Sotrovimab for that sort of patient, or if Paxlovid supplies dry up. To me, Molnupiravir is the third kid off the block, mainly because it has such low efficacy. At 30%, you want to make sure that the patient gets drugs with very high efficacy before you default to Molnupiravir. I guess that's my tier. Al, did you want to comment?
Yeah, look, I'd agree with that. And I think particularly for populations where access to Sotrovimab is challenging, there will be some logistical issues about getting drug out to people. But I think for the people we talked about earlier who have great difficulty leaving the house, or indeed in rural and regional settings, Paxlovid will be a great medication in that setting. Yeah, I think Molnupiravir, for all the move into residential care, I think there will be some challenges with using it, let alone its efficacy. And my understanding is that we would only give it in people who are symptomatic. Is that your?
Yeah. Yeah, that's my understanding, Alistair. And I'm presuming that it's gone to residential aid care because it's relatively safe to give in that patient population.
Yeah, absolutely.
So there's another question. Did the studies on either of the oral antivirals include elderly patients? Patients in aged care facilities who are triple vaccinated, is it up to the discretion of the GP to give the antiviral treatment as indication for those who are single or double vaccinated?
The answer is yes, elderly patients were included. I didn't have time to show you the complete patient distribution. I'd have to go back to the original slides. The problem with Paxlovid, it still hasn't been released as a publication, as often happens. You get a press release. So the slides I've got are limited in number, and they were what I could scrounge with Pfizer at short notice. I'm pretty sure there were patients who are elderly. I just can't off the bat tell you how many there were. The second part of the question, Nicole, sorry.
The sort of the triple versus double or single vaccinated aged care patient, is it just up to discretion who you give it to?
Well, we sort of presented the guidelines that the Department of Health has formulated, and I think we should be consistent in who we give it to. The problem is that, as I mentioned, those guidelines are going to change, so I think we need to follow them.
And then there's a question, a patient calls up and says they've got COVID on a, potentially on a rash. Would you prescribe based on known history, or would you chase confirmed COVID result, pregnancy test, renal function before prescribing? prefer to do that, but concerned about missing the treatment window.
So what's the exact scenario, please, Nicole?
So I think it's you have a patient who says that they have COVID, and you don't have, say, recent renal function on them, or you don't actually have the ability to do a pregnancy test. I guess you could send them out get their local chemist to send them one, and they might just have a positive RAT. So, do you have to chase a confirmed COVID result?
So to my mind, a RAT test is a confirmed COVID result, and it's accepted as such at the moment. The problem is that it just doesn't have the sensitivity of a PCR. So in a symptomatic patient, it's got appropriate symptoms or epidemiology, I'd be comfortable. I really wouldn't need to go chasing a PCR in this day and age.
And renal function, especially in elderly people who don't have renal function in the last year or so.
Yeah, I think I'd like to know what their renal function is. It depends on who they are, I think, Nicole. You get someone who's otherwise healthy in their 30s, who has a comorbidity where renal function shouldn't be impaired, you could probably wing it. And an older individual, I think I'd want to know what the EGFR is.
Yeah. And there's a question about, I assume Pexlovid cannot be used in HIV patients who are already on other boosted PIs.
Great question. Can I take that on advice? I think it can. It was my memory of it. I'm presuming it's someone like Kelvin that asked that question.
It was Lester.
Lester.
Okay.
So can I get back to you? Yeah, sorry. I'll get back to you.
5 questions that appeared very quickly. Must have been my updating. So residential aged care patients with eligibility criteria without respiratory symptoms, would you still, so just, symptoms of mild COVID, but not respiratory, well, actually, no, without respiratory symptoms is the question. Would you still initiate molnupiravir?
Does that mean totally asymptomatic or patients with a fever and no respiratory symptoms?
Maybe do both.
It's indicated in patients who have symptoms, so I don't think we can use it in completely asymptomatic. Someone's febrile, they got a positive RAT test or a PCR, I think that would be fine.
Yeah.
Al, what do you think?
Yeah, I'd agree, Joe.
Yeah.
And do medications reduce the risk of long COVID?
Not that we know of.
And the recommended management of an adult with recent myocarditis, not COVID, and partially vaccinated. Tricky one, Kathy. So someone who had recent myocarditis and then gets COVID and is partially vaccinated.
So the current recommendations are that it has to be at least 3 months beyond that before you're willing to give them an mRNA vaccine.
Yep. And if the studies were done on people who are not vaccinated, how are we certain that the findings will help patients who are vaccinated?
Well, I think the issue is that it's the other way around almost. I mean, there's no reason to believe that the drug won't work in someone that's vaccinated. The issue is if you're vaccinated, you're probably even lower risk than what we saw in the study, hence the issue with risk stratification.
Yeah. And there are any dietary contraindications for Paxlovid?
No.
And then just going back to an earlier question, there was a study published by the CDC at the end of January showing that if you catch a natural infection, having a vaccine did not reduce the risk of hospitalisation. It was done from May to October during Delta and Alpha. Any thoughts on this? I mean, the question is going to be on the time stamp of that vaccination relative to the infection.
I'm not quite sure what the question is again, though, Nicole.
Well, just I think maybe because I presented that data around the New South Wales data showing that vaccination made a difference to hospitalisation, certainly. Sure. But then there's this study published saying that it didn't make a difference, didn't reduce the risk of hospitalisation, and it was done from May to October 2021 it must have been.
So was that
Anyway, there's
around vaccination or treatment, Nicole?
no, it's around vaccination. Sorry, this was a jumping.
I think the other thing to reinforce is that if someone's had COVID, we do recommend that they get follow-up vaccine. So I think that's important, and it sort of ties into what you're saying. And then the other issue that we always wrestle with is what is the optimum time following a case of COVID that is appropriate to vaccinate? And there's no real consensus. It's anywhere between the end of your symptoms right up until 6 months. Now, earlier on, we were suggesting that people get it done earlier, simply because there was a lot of Omicron around and we wanted to cover it. I think currently most people would recommend roughly 3 months, but that's a rule of thumb. And there is data to suggest that if you vaccinate later, you get a better immune response. So it's a balance about making sure you're covered in a reasonable period of time, but getting a reasonable response. And if you vaccinate too early after a COVID infection, your immune response to vaccine is blunted.
Okay, I think we've just got a few health pathway slides that we were going to finish off on, and trying to bring this home in the next 2 minutes, because that's all we've got left. And we know everyone's keen to go and get on with their evening. So just very briefly, health pathways. The COVID health pathways has been the most viewed pages, I think, on the health pathways website. And there are various ones, including specific to our health pathway in the Northwest. And I presume we've got people from various various PHNs in this call, because we usually do. We've had some updates to all of those, and there'll be, further updates and links as these oral antivirals become available. And we've also got some new respiratory clinics that have also being rolled out in the region. There's health pathways. You have to log in. You can get a login easily from your local PHN, and they've got assessment, management and referral for COVID-19. They've got the inclusion criteria for sotrovimab, and they also have a link to the updated information, although it's updated on a government website, so sometimes it's not as updated as you like it to be, but there's a link through to that, the information that Al showed earlier of the different services and what their times and contacts are. Was there anything else I needed to say about health pathways?
No, all good. Thanks, Nicole. Just as we're finishing up, I do just want to thank you, Nicole, for your facilitation. That was great. Those questions were coming in thick and fast, but I think shows just the interest in this area. Thank you to you for your time tonight, and also to Joe and Alistair for presenting what was a really informative session. And it sounds like there's a lot more sort of changes to come in the next little while. So we'll certainly be communicating any of that through, as Nicole said, health pathways, but also our communications and potentially further education sessions. And just a big thank you to the participants. It's an incredibly busy time for everyone in health at the moment. So really appreciate you giving up part of your Wednesday night to be here and join us for this session. I think Hamish, my colleague, has popped an evaluation in the chat, so please jump onto that link, give us some feedback on the session, and particularly any other additional sessions that you'd like around COVID or otherwise. But thank you so much again to our speakers for being so generous with your time, and to Nicole for facilitating. And thanks everyone for coming. Have a good night.
Thanks, Bianca and the PHN.
Thanks, guys.
Thanks, everyone.